Okay, so welcome to everyone who's joining us remotely. We are doing metabolic disorders, and let's go ahead and start with this first one. Shane, you want to start us out?
Sure. So there's some hyperkeratosis, maybe a little acanthosis underlying that.
And it's kind of an irregular acanthosis, right?
And then under that, there's a little inflammatory in circulation. Lots of pink amorphous. I don't know if it's reduplicating around the vessel or is it actually deposits.
So look up on the screen. Does it look more... There's your vessel. Mm-hmm. Does it look more like circles around the vessel or more like round blobs?
More like round blobs.
More like round blobs, mm-hmm. Right? And round blobs around about the size of keratinocytes. So what do you think?
So given the LSC type presentation, maybe like an amyloid?
Yeah, exactly. So like an amyloid is basically fancy LSC. It's fancy lichen simplex chronicus, where you've scratched so much that you've mummified some of those keratinocytes and they fall off into the dermis as amyloid. So very good. One thing that this one does not show that some LSC shows is little whorls in the stratum corneum, similar to what you see in Still's disease and incontinentia pigmenti. So that's, those three you have to think of in the same differential. Okay.
Okay, so this is a pretty deep punch.
It's a pretty deep punch.
It looks like the collagen looks maybe a little abnormal, maybe some extra space between some of the collagen
Yeah, so
bundles.
you'd wonder if there's extra space between the collagen bundles, especially at the deep margin. You might stain it for mucin, thinking of things like scleroedema of Buschke, and that's about it. I don't see a whole lot else in there. So, possibility of a subtle scleroedema, which is what the history was.
There seems to be a subepidermal split, which I can't tell if it's artifact or true from this.
Any other clues that suggest whether it's artifact or not?
I think it's true just because of the separation. Yeah, that you're letting the caterpillar bodies that are in there.
There are caterpillar bodies up in the epidermis, suggesting that this split with solar elastosis, festooning, and just a little narrow cuff of hyalinization around the vessels actually is
PCT.
Okay, so porphyria cutaneous tarda is virtually always on sun-damaged acral skin.
So then you would think EPP in this.
Say again?
Something like EPP or something like else.
So as opposed to EPP, erythropoietic protoporphyria, which is always on non-sun-damaged skin, because their skin hurts too much in the sun for it to become sun-damaged. PCT is virtually always on skin with solar elastosis. Just a little narrow cuff of hyalinization around the vessels, festooning, subepidermal bulla, and very commonly the telltale caterpillar bodies, which is trapped basement membrane zone from where there has been prior blistering.
guess there's like some scant inflammation, but the most prominent thing to me is pretty square biopsy, a lot of collagen space, scleroedema, I would say, now extracellular.
Yeah. So similar again, you got a big thick dermis, you've got some increased space between the collagen. No extra collagen is made in scleroedema, but because the collagen's pushed apart, the dermis becomes thicker and thicker just because of the widened space between all of those collagen bundles. So it's a very thick dermis, no new ropey collagen, but a little bit of increased space between collagen. And then put those together and it suggests. Sorry about that. I'm dying.
Need some water.
No, I think I'm okay. Thanks. Okay. Sorry. I don't think I'm contagious anymore. It's just the tail end. Let's see. Is there any more of that? That's about the tissue that we get.
Small little biopsy here. It looks like it's on probably facial skin of some sort.
Yep.
There's some artifact there. We have what appears to be a little bit of mucin. So you think about like gold deposit
So gold would be one possibility.
or silver.
What do you think it's depositing on, that pigment?
It looks like the follicles. Or, sorry, I can't.
Well, fibers, right?
Yeah.
And there, if you stain them, you'd see that's elastic fibers that it's depositing on. And with time, they would turn into banana bodies. But this is just early, so it's ochronosis, early ochronosis. Doesn't this look a lot like... Take that to sign out today. Actually, rub it with alcohol before you do that, because I just coughed. Let's put it down here. We'll decontaminate it and then take it to sign out today. Yeah. So here. Do you want to drop it in a pocket? And you can decontaminate it. I didn't see that you were all there. That's why we were taking it to sign out. Yeah. Just, how much it looks like that case of blue nevus we had. That's what early ochronosis does look like. So. Okay, let's skip that. Sorry, I didn't see you were all three sitting there. Let's get... Okay. Okay.
Definitely widening of the collagen.
And does the collagen itself look normal, like in scleroedema?
No, it's thickened in some areas. It looks like kind of attenuated in some other areas. But yeah, it's kind of like hyalinized. And it could be amyloid there as well.
Yeah, so how would you know?
You stain it, Congo red, and other stains.
Yeah, so Congo red, bioflavin T are probably your best for systemic types of amyloid. And with bioflavin T being your most sensitive, but you need an IF scope to look at it. And for epidermally derived amyloid,
Crystal violet?
then crystal violet. Yeah, so if you're looking for a subtle macular or lichen amyloid, crystal violet's your stain. Whereas for systemic amyloid, if you want something really sensitive, thioflavin T is your stain. the reason people do things like Congo red is that they may not have an IF scope handy. So this is a Congo red, and I know that Nicole already polarized for you earlier. That's what primary amyloid, like a lichen amyloid, looks like with Congo red. It doesn't really pop out at you that much, which is why crystal violet does better for the epidermally derived amyloid. This one would be a good one.
So let's see, it looks like increase in, I guess it's mucin throughout, and kind of wispy collagen. I was trying to decide if there was an increase in fibroblasts or not, but looks like there might be, so like scleromyxedema.
So scleromyxedema, do you have too much collagen or too little collagen?
I guess it would be the opposite, too much.
Too much, and here you have too little
So like
collagen.
pretibial myxedema.
So pretibial myxedema. So scleromyx tends to affect only the upper third of the dermis until it's very late stage disease. And what you see is not so much an increase in mucin. Your eye doesn't really pick that out. What you pick out is an increase in cellularity and collagen. So there's new ropey collagen and too many fibroblasts. That's what you see in scleromyx. NSF looks just the same, but NSF starts deep in the septa. Scleromyx starts in the upper third of the dermis. Pretibial myxedema is through and through the entire dermis. You have attenuation of the collagen bundles, so instead of being big and thick, they are thin and wispy in a background of mucin. Stasis mucinosis looks identical, but only affects the upper third, whereas pretibial myxedema is through and through. So this one is a big leg, sort of big verrucous, lumpy, bumpy leg with a question of pretibial myxedema. What you see is massive hyperkeratosis, papillomatosis, dilatation of vessels, fine ropey collagen. If you stain it, there's a little edema there, but it doesn't look like pretibial myxedema. This is elephantiasis nostra varicosa. It looks like chronic lymphedema in the leg, giving you a localized elephantiasis. So that would frequently be, there are lots of things that don't belong in this spot, frequently be in the differential. Okay, so Blake, what do you think?
So it looks like there's another subepidermal split. You can see caterpillar bodies as well.
And in fact, this is a very sine wave-like caterpillar. More like an inchworm, right? The way it's arched up. But you definitely have caterpillar body there. Less festooning in this case, but it is on elastotic skin. Caterpillar body present. So that makes sense for
PCT.
Got a lot of repeats in this box.
I'm seeing a lot of collagen, potentially spaced.
And is there more space up above or more space down below?
More space down below, I would
And
think.
is there something between the space, filling up that space?
Kind of grayish blue, probably mucin, I'm guessing.
Yeah. So basically snot, right? Like my cough a little while ago. There's all that phlegm between the collagen bundles pushing it apart, right?
Yep. Or scleroderma.
So scleroderma, and scleroderma is associated with, because on your path test, the answer may not be scleroderma. The answer may be an association, right?
Mm-hmm.
So what's the most common association with scleroderma?
Type 2 diabetes?
You are correct. Well done.
These are not
Type 2 diabetes. And derm guys, you maybe all know that it's type 2 diabetes, so maybe the second most common association. Yes. So strep would be another, probably, maybe second most common, maybe tied with what else?
Gammopathy.
Gammopathy. So you have to look for, so when you have a patient with scleroderma, you look for history of diabetes. It's usually established type 2 diabetes. You can just ask the patient typically. An A1C may be reasonable if they say they're not diabetic. And then looking for recurrent strep infection and looking for paraproteinemia. In my experience, the streptococcal ones look different. So whereas your typical diabetic is red, indurated, hard skin of the upper back, your scleroderma post-streptococcal, you look almost like the Michelin tire man. Just your whole body inflates with mucin. So I've only seen it twice, and the one guy was 32-year-old guy, got a strep throat, and then when I saw him, he could not bend his fingers, he couldn't put his arms down. I mean, he really looked like the Michelin tire man, and then he just slowly deflated over about a year.
There's no therapy that helps it, right?
Not really.
Yeah.
I mean, you could. I mean, we talked to him about things, about methotrexate, things to try to poison those fibroblasts, and he was slowly going back to normal. And so, the only drug that he wanted was he was put on strep prophylaxis for life.
That seems fair.
Yeah, which, considering his body doesn't do well with strep, that seemed to be a very reasonable thing to do.
Could you inject hyaluronidase?
That would be a lot of hyaluronidase. Buy it by the barrel.
This also is like an increased space between collagen.
So increased space between collagen. Does it look like back skin?
No.
Not particularly, right? So for this one, there's mucin, but you sort of need to know what's going on clinically. This was taken off, thought to be a neurofibroma. So do you know any kind of focal cutaneous mucinosis?
Like a focal cutaneous mucinosis?
Yeah, like focal cutaneous mucinosis, yeah. And what if this person who has focal cutaneous mucinosis also has blue nevi and freckles? And Pseudomonas melanotic schwannoma and epithelial blue nevi. Carney. So Carney's complex, focal mucinosis is one of the things that you can get in it. And then in those patients, you have to look for an atral myxoma. That you have cutaneous myxomas and acral myxomas. Okay, let's see. Something a little bit different.
It's one of the few derm things that
I know. It's easy to remember.
think on that piece.
So
pretty normal. Strong corner dermis is real attenuated. And the dermis is pretty sclerotic. Looks like I don't appreciate an increase on their fibroblasts.
So I agree. It looks, if anything, maybe hypocellular, but with sclerosis. So what does it look like?
It looks like a superficial biopsy of morphia.
Yeah, it looks like morphia, right? What other things can produce morphia-like or scleroderma-like changes in skin?
Sclerodermoid GVHD.
So sclerodermoid GVH is on that list. What else?
Some of the deeper like radiation changes.
So radiation dermatitis is on that list. Anything in the metabolic chapter?
Probably.
And long-standing porphyria, especially PCT, is on that list. So this is a patient with long-standing porphyria cutanea tarda who developed scleroderma-like changes. So sclerodermoid GVH, sclerodermoid PCT are on that list of scleroderma-like things.
So there's lots of looks like blood and serum, and then maybe some I don't know if there's some necrosis in there. There's some vascular channels and
How much collagen is there? Not much. Most of that's just blood vessels, right? And why is it so blue? What's in there?
Well, it's inducing.
Yeah. So
this could be neuroptosis.
yeah, it could be. I mean, your question is where this is from. It's just kind of myxoid tissue, like an angiomyxoma or just a myxoma. And this is a big nodule taken out of someone's heart.
Think of an atrial myxoma.
Like an atrial myxoma. And this person had endocrinopathy. And this atrial myxoma, what skin lesions might they have had?
Lentiginous.
So lentiginous and blue nevi and epithelioid blue nevi and melanotics, pseumomatous schwannoma. So that's, from someone with Clarny's, diagnosed because of their cutaneous findings, and that was the big undiagnosed myxoma bobbing about in their heart.
That was the heart?
That was from a chamber in
Dr. Elston.
we said it before, there is no organ of the body that cannot be reached with a 4mm punch and a good strong arm, right?
So this looks like a well-circumscribed lesion. It's very myxoid or mucinous. The cells from here don't look very big. It looks intramuscular.
Yeah.
So I'd call it I'd make sure that there's nothing pleomorphic or strange closer up, but I'm thinking an intramuscular myxoma.
Yeah. So intramuscular myxoma, and then if it were distinct pools, like islands, then you might think of a myxoid schwannoma or myxoid neurothekioma, nerve sheath myxoma. This is more diffuse. You could think possibly of a myxoid neurofibroma and do a neurofilament stain. And if it's negative for all of those, then it's just an intramuscular myxoma.
So the upper dermis looks mucinous with some wispy.
Yeah, so there's mucinous and wispy collagen. Came in as rule out pretibial myxedema. What do you think?
Maybe it's like stasis mucinosis.
Maybe it's like stasis mucinosis. So do you see any angioplasia of vessels and hemosiderin deposition? There's plenty there, right? So this is stasis mucinosis affecting only the upper third, mimicking Pretibial Myxedema. Very good.
So, looks like there's a lot of mucin.
Sorry. So a lot of mucin.
More wispy collagen fibers.
And kind of goes through and through, right? I'm going to go wash my hands and get some water. So if this were on the shin of a 40-year-old male, what would you think that 40-year-old male might be suffering from? Graves' disease, exactly, because it looks just like Pretibial Myxedema, right? This is actually an animal that was bred,
Oh my God, I love that.
a pet who's bred to have an entire body that is basically Pretibial Myxedema. It's a Shar-Pei. So Shar-Pei dogs, the reason they look like they do is they're bred to have widespread cutaneous mucinosis.
Is this really a dog biopsy?
This is a Shar-Pei.
They take that dog
But
dermatologist
it
for
looks
everyone.
just like
Yes.
Pretibial Myxedema, right? So, and you know, you will probably never have to read a biopsy on a Shar-Pei, but having seen this slide will make you remember much better what Pretibial Myxedema looks like, right?
Did you perform the biopsy?
Did I perform the biopsy? I did not.
Okay.
I got it from a veterinarian friend. Because for a derm, that's pretty cool. Right? Okay.
So what happens if a Shar-Pei gets Pretibial Myxedema?
Yeah, exactly. They pop. Okay.
So I'm not seeing much at low power. At this
Not
point.
seeing much.
So it's a little bit of post-inflammatory pigmentary alteration, or maybe, yeah, it looks like that. And perhaps amyloid, like macular
Yeah,
amyloid.
little gray amphiphilic chunks of amyloid. All epidermally derived amyloid is surrounded by a very fine network of melanin, pigment incontinence. So when you look, you see between those chunks, there are little long processes with tiny little bits of melanin in it. That's true for macular amyloid, for lichen amyloid. They always have that network of pigment incontinence present there.
Here's this fissured material throughout the dermis.
Yeah, so when you see fissured material in the dermis, what kind of things do you think of?
Well, it just triggers me to talk to my dermatopathologist about staining the area. But nodular amyloid, like colloid milium, could be.
Yeah,
in
exactly. I mean, that's pretty much your differential, either colloid milium, nodular amyloid. So one of the things you look for is to see, is there obvious transition between solar elastotic fibers and the material as you would see in colloid milium. If it's not there, then it heightens your suspicion for amyloidosis. One of the other clues for amyloid is you have red cell extravasation, right, which you tend not to have in colloid milium because the amyloids in the vessels too makes them brittle, and so they tend to bleed. Okay.
Yeah.
Yeah.
Déjà vu, ici,
So, James.
Oh. Yeah, I was going to say scleromyxedema, but they were telling me stasis.
So you were apparently blinked the last time we saw this one. So why is it stasis rather than scleromix?
Because it's only in the upper 1/3, which is classic for stasis.
And where is scleromyxedema?
The whole kit and caboodle.
No, that would be pretibial myxedema. Scleromix is also the upper third.
Okay,
So how do
that
they
fact's
differ?
not helpful at all.
No, in fact, they're both upper third. So this has, first off, it has nodular angioplasia, it has fibrosis, it has hemosiderosis, all of which suggest stasis. But when you look in the upper third here, there's increase in mucin.
Mm-hmm.
Is there increase or decrease in collagen?
Decrease.
Decrease. An increase or decrease in cellularity? I'd say probably decrease.
Probably
You don't see a
decrease.
whole lot of cells there, right?
Yeah.
Not a whole lot of nuclei, whereas in scleromix, you don't really see the mucin. What you see is increase in ropey collagen, increase in nuclei in the upper third of the dermis. So distribution is the same, upper third, but here you have wispy collagen, few nuclei, lots of mucin. In scleromix, you have lots of collagen, lots of nuclei, not much mucin.
Fantastic.
Let's see what else we got here. Let's move to the second box. See if we've got some different stuff in here.
So you have a deep biopsy here. Looks like there's some hemorrhage, thickening of the collagen. It's pretty cellular with some neutrophils.
Yeah, we're sort of all the way down to what kind of tissue?
Fascia.
Yeah, or fat,
septal, yeah.
right? And everything here is kind of dead and inflamed up
Mhm.
above. You have all your vessels contain thrombi,
Mm. Yeah.
so it's kind of dead, infarcted. You've got what going on there?
It looks like there's some calcium deposition there.
And so is that a big vessel, small capillary vessel?
It's pretty big.
Pretty big vessels. So that would be what?
I'd be concerned about calciphylaxis.
So calciphylaxis is what's diagnostic of that big vessel or little capillary vessel disease?
I always thought it was big vessel.
It's the little capillaries that are diagnostic. So this is atherosclerosis, what's called Monkeberg's medial calcific stenosis, which is part of just atherosclerotic disease. So what you have to do for calciphylaxis is look at the little thrombosed vessels and see if they have calcium. And that often requires a von Casa stain. And you're looking to see, are the tiny little capillary vessels also calcified? If they are, and they're thrombi, that goes with calciphylaxis. And then the two things you can address therapeutically in calciphylaxis, you can address the thrombi with things like TPI, and you can address the calcium with things like thiosulfate. So both of those are used in treatment of calciphylaxis.
Dr. Elston, could you just explain like the clinical appearance? Because the clinical appearance is more, stellate and larger vessel.
So it's retiform purpura with induration. So retiform, most of the vasculitic things are retiform purpura with no induration.
But retiform
purpura
usually
and-
suggests more of like a medium vessel etiology, right? I mean, that's how you get that retiform look.
It
Not capillary.
is often associated with a medium vessel occlusion. That's true. In calciphylaxis, you often have thrombosis of the medium vessel as well,
It's just
which
not
probably
characteristic.
relates, but it's not the diagnostic feature. The diagnostic feature is that it goes down to every last little capillary that is calcified. So it's like you crackle when you walk because of all that little capillary calcification. So that's what's critical in establishing a definitive diagnosis of calciphylaxis. Okay, so let's do, what do you see here?
Looks like a lot of mucin all the way through the dermis.
All the way through.
Attenuation of collagen fibers, hypocellular.
So hypocellular attenuation of fine ropey collagen fibers, mucin through and through.
Pretibial Myxedema.
Yeah. So if your patient's not a Shar-Pei, right? The two look the same.
So we see an increase in cellularity with kind of some kind of pale pink to gray amorphous material. Or is this all just collagen?
You tell me.
So I mean, it looks like there's some fiber in there, and that looks kind of like pale. I would say like a nodular amyloid. Maybe.
So amyloid is a possibility. I think, did you say fibrin?
What is that?
Fibrin always takes up much more stain than anything else.
Okay.
Usually even more stain than epidermis.
Like the bright pink.
These are pretty pale, right?
Right.
The bright pink here is red cell extravasation.
Okay, that's what I was calling.
And way too red to be fibrin. Fibrin's amphiphilic but takes up a lot of stain.
Okay.
So if that's vessels, there's a lot of hyalinization around the vessel and really kind of thick. So you stain it for amyloid and it's negative, but you stain it for type 4 collagen and it's positive. So it's all basement membrane zone, but it's really widely hyalinized.
So like lipoid proteinosis?
And so lipoid proteinosis absolutely would do that. It's just masses of this big mantle of this basement membrane zone material around the vessels, but it's restricted to the upper third. You look down deep, in lipoid proteinosis, it's just as prominent down around the sweat glands. Here it's only the upper third, so it looks like lipoid proteinosis, but only affects the upper third.
Okay. So like EPP maybe?
Like erythropoietic protoporphyria. So when you see those big basement membrane zone mantles around vessels, your differential diagnosis is lipoid proteinosis, which would go through and through. In fact, becomes even more prominent the deeper you get. Or EPP, which is only the upper third where the sun can get to it. So that's characteristic EPP. Okay, so Blake, let's start down there.
So it looks like some increased space between the collagen fibers.
So maybe increased space, or maybe just normal. So
Okay.
if that's normal, let's move up. So what's abnormal about the top compared to the bottom? So if the bottom was normal, how is the top different?
It looks pretty similar to me, to be honest.
Anyone else want to jump in? So first off, how many nuclei do you normally have in the dermis?
Few.
And up here, it's a little bit busy, right?
Mm-hmm.
And your normal collagen bundles in the dermis are all pretty uniform and big. When you get up here, are they all uniform, or do you have big ones and thin, ropey ones?
That one.
So it's the second. So you go to the upper third, and it's pretty subtle. But the only subtle changes you have is a subtle increase in cellularity. It's kind of a busy dermis, too many nuclei. And you've got thin, ropey collagen in between the normal collagen bundles.
Scleromix.
It's scleromix. That's exactly right. And scleromix is usually a sign of underlying what? Gamopathy, paraprotein. And it progresses to a horrible, debilitating scleroderma-like disease. So, important diagnosis, horrible morbidity, and histologically, when you have to make the diagnosis, pretty subtle. It's just an increased cellularity, almost like a dermatofibroma or interstitial GA, that it's just kind of a busy dermis. But you've got, in addition to your normal collagen bundles, you've got thin, ropey collagen mixed in.
So how would systemic fibrosis look different? Is it just
systemic fibrosis? You have no thin, ropey collagen. Your pre-existing collagen becomes hyalinized and widened.
Okay.
Here, the problem is you have new, thin, ropey collagen fibers being made between the pre-existing collagen. So you still see your old collagen bundles that are normal, that look just like the ones down in the dermis down below. But in addition to that, you've got these new, thin, ropey collagen fibers, and you just have a subtle increase in cellularity, a little bit busy dermis. That's what scleromix looks like. Those exact same changes, but in deep septum, is what nephrogenic systemic fibrosis looks like.
Inflammatory morphia, or something like early superficial morphia. What else?
So early inflammatory morphia, the changes, it's hyalinization and widening of the collagen bundles, and nodular lymphoplasmacytic infiltrates down by the fat, deep.
So I'm seeing a lot of spacing of the collagen bundles, both superficial and more prominently deep.
And more prominently deep, and what's between the collagen?
It's like that blue-gray wispy material, probably mucin.
So blue, stringy, and granular stuff. So mucin between the collagen. So this is
Pretibial Myxedema.
Is pretibial myxedema just deep, or is it through and through?
It's through and through.
So which one is just deep?
The sclerodema.
Sclerodema of Buschke. Correct. And because the associations are very different, it's important to remember which one's which. Yeah, hyperkeratosis, papillomatosis looks kind of warty, or LSC-like, kind of indurated. What do you see in your dermis?
Some polymorphous material there.
Yeah, and where is it?
Just like right around the vessels.
Yeah, like it is the vessel wall itself that's thickened and hyalinized. So what do you know that produces these hyaline cuffs around vessels in the upper dermis?
EPP.
Like EPP, and this one, it really stands out there that you see that it really is the vessel itself and the vessel wall that's hyalinized and red. Let's get the arrow there so everyone can see. So you see that, it's thickening of the vessel wall itself. This is a shave, so you can't really see that it's just the upper third.
Right.
So what else could this be?
Lipoid proteinuria.
Lipoid proteinuria. So lipoid proteinuria just gets worse and worse the deeper you get, whereas EPP is only the upper third. What does your typical patient with EPP look like?
They're pale. They don't get out in the sun much.
Well, they don't get out in the sun much. They usually, the skin is red, indurated, a little bit lichenified. Looks almost like a bad sunburn with a little bit of very delicate crust on it. You'll see it in kids who scream when mom makes them go outside to play. They say the sun hurts their skin. You'll also see it, not uncommonly, in active duty people in basic training who have this, horrible reddening, thickening, burning of their skin. And when you talk to them, well, they got to do gym indoors when they were a kid because the sun hurt their skin, and now they're in the military and they have no control over their environment. They're doing PT outdoors and they're presenting with their EPP.
This one looks hypercellular to me.
Looks hypercellular. Looks kind of like a hypercellular busy dermis, right?
I'm in the scleromix category.
So scleromix, what other things are in that category?
NSF.
So NSF tends to begin in the deep septa. Scleromix begins in the upper third of the dermis. Interstitial GA, subtle dermatofibroma. Those are all things in that busy dermis differential. This one tends to be the top. Patient had a paraprotein, and so this was a scleromix is the way it turned out.
It's pretty pale. Could certainly be that it's chock full of mucin. And if that's the case, it looks like maybe there's some wispy collagen, some more like Pretibial Myxedema.
Does it go through and through, though?
It seems to spare the upper third. So
yes, spares the upper third, which would be a little unusual for pretibial mix, certainly unusual in a Shar-Pei dog, right? Because it's the entire dermis that's affected in those.
Could be sclera edema, and it's just the collagen's not staining very well.
But in sclera edema, does the collagen become attenuated and wispy, or is it normal, just pushed apart?
Normal.
Normal, just pushed apart. So then this, you're left with certainly a dermal mucinosis. You got wispy collagen, but unlike pretibial myxedema, it spares the upper third. And this is just a punch out of a focal cutaneous mucinosis. Right? But you've got clues there that there's something wrong with that being pretibial myxedema.
So it's definitely a deep biopsy, but the dermis looks maybe a little thickened. I can't tell if there's increased cellularity.
Yeah, I don't see increased cellularity. Maybe a little increased space between the collagen below. So why, in some of these, do we see all the blue-gray stuff between the collagen, and in others it's just clear? What's the difference? And the difference is whether it was stained in a lab that just does Dermpath or a lab that also does GI. Because if you can see mucin, it drives the GI people nuts. They're constantly dialing down the hematoxylin on their stain, whereas Dermpaths are we wanted it to look like all of our patients died of hematoxylin poisoning, right? We're constantly dialing up the hematoxylin, they're always dialing down. Now on the new stainers, like here, the slides are barcoded, and it knows whether it's a derm slide or a GI slide, and it just adjusts the stain accordingly, so that we get to see our mucin and they don't see their mucin. So here we have a beautiful mucin stain with it visible in the dermis, whereas in labs that don't have those fancy barcoders, if they're staining all kinds of specimens, you usually don't see mucin, you just see space. Whereas in a dedicated Dermpath lab, we dial up the hematoxylin and you can see it. It stains the mucin. Okay. And with that, I mean, we're close to the end. Everyone needs to disinfect, so we will call the session at that point.
We're set.